Good afternoon. My name is Carlos Becerra. I'm a medical oncologist by training, and I work at Baylor University Medical Center in Dallas. My main areas of interest are GI oncology with a special focus on pancreas adenocarcinoma studies, of which I have several available. The question is, what imaging and lab testing is needed at the time of initial pancreatic cancer diagnosis? Pancreatic protocol CT with contrast plus CT chest with contrast versus MRI or PET. And when is an ERCP or EUS needed? At diagnosis, I request a CT of the chest, abdomen, and pelvis with contrast in order to determine the exact location of the primary pancreatic lesion, its involvement of adjacent structures such as the celiac axis, abutment or invasion of arteries, presence of vessel narrowing or tumor thrombus, presence of enlarged lymph nodes and distant metastasis. I continue to use a CT of the chest, abdomen, and pelvis on the restaging evaluation, unless I have questions about findings on the CT that I think might require additional imaging to clarify the findings. For example, in the presence of equivocal lesions in the liver, I might request an MRI of the liver to clarify the findings, or in the presence of a rising CA19-9 with a normal restaging CT scan, I request a PET scan that will elucidate the presence of recurrent disease. Keep in mind that there are other potential benign explanations for the patient's elevated CA19-9, including gallstones, biliary infections, pancreatitis, pneumonia, pleural effusions, renal failure, interstitial fibrosis, and COPD, among others. In my practice, most patients that I see for the first time already have been previously seen by a gastroenterologist who have performed both an ERCP to relieve obstruction from the primary tumor, compressing the common bile duct, and an endoscopic ultrasound with an FNA of the pancreatic lesion to ascertain the diagnosis. In the few instances where I see the patient in consultation before the gastroenterologist, I refer the patient to the specialist if the patient presents with obstructive jaundice and requires a stent placement, or has not had a tissue diagnosis and either has localized disease or a CT guided biopsy that is technically challenging for the interventional radiologist due to the anatomic site of the metastasis or the size of the lesion.